Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gawain Vaughn.
Welcome to the Auburn Medical Group live stream on YouTube. We are glad you joined us.
Yes.
And if you're new to this, we do this live at 4:30 on Monday afternoons, and you can also watch it at what?
I said 4:30 Pacific time.
It's Pacific time. And you can also watch it afterwards on YouTube because it's still there to see. And we have
That happens.
Dr. Mark Vaughn, and we have Dr. Gawain Vaughn,
That's me.
and we have our announcer, Mr. Ed. Welcome.
Mr. Ed. Hello.
Yes, and we're. Is that comments that we're already getting, or is that not real comments?
Everybody says
not
hi.
real.
If you're watching
No.
live, you can actually comment. We'll look at your comments and read them during the Mr. Ed will read them.
We'll try.
We'll try. Today we're talking about your blog post. on
Which is,
DrGreeNight.com.
what is my blog
Value-based
post?
care.
Oh, okay, good.
I was waiting for him,
Oh, okay.
if you believe that. I was on TV this weekend.
Were you?
I was. Did you know that?
No, I don't watch TV, so.
I don't either.
Which
I saw,
one?
I saw it. Channel 3. Channel 3 News.
Oh, yes. Local.
So Orko Manicol wanted to ask me some questions about COVID,
That's
and
the person's name?
he's the reporter.
Oh, okay. I don't know who that is.
He's on Channel 3.
Orko Manicol.
So, no, he called. Orko Mana called.
Okay, I was going to say, Orko Manicol sounds like something in
No.
the ocean.
No. Orko, not Orca. So he called, and he wanted to ask me about COVID and being out and being part of these festivals. Or specifically, they had I think it's called-
Coachella? No.
Look at this, you
Brittany
guys.
Hope went to Coachella, but not Orca. What?
You're getting a call from Michigan, from Chicago, from Scotland, from Mississippi.
Oh, are people saying where they're from?
Hey!
That's terrific.
Welcome.
Not Coachella, but all these other places. My
Welcome
goodness,
to
look at all of these people
Auburn.
who are commenting on our show. Thank you. We're glad you're a part of the show. And Super Chat is open too. Just thought I'd throw that out there because, some people did have Dutch brothers. So Brittany Hope is at Coachella. She's also a reporter on Channel 3.
Okay.
Orko Mana was at Beer Week is what they call it. So he wanted to ask
Year
me,
week.
COVID-wise, should people be worried or just concerned and watchful?
Please
And
tell
I
me
said
the
just
difference between worried and concerned.
Okay, watchful. And so I said, alert, watchful, keeping an eye on what's going on with COVID, but go ahead and celebrate their festivals and whatever for now. But the numbers are coming up,
Yep.
and they're...
Make sure you're vaccinated.
Yes, there you go. That's the biggest advice we have. And for those of you who don't benefit as much from the vaccine because you have some kind of illness that makes you immune compromised, you can now get the antibodies, the monoclonal antibodies through your doctor or your rheumatologist or your oncologist.
Preventive.
So do talk to your doctor about that option. And I do believe that we have the option of our patients getting it at the infusion center
Yeah. Go.
or at the hospital
say it
for those
goes
people who are
through them.
especially vulnerable because this COVID, the BA2 variant, which seems to be the one that's most prevalent in California now, can hurt people. So do be aware of that.
Yep.
But thankfully, for the most part, people have made their choice, gotten vaccinated, or have a little bit of immunity hanging on from when they caught it.
When they
So,
had it, like everyone.
Yeah, we're in a
Most
much
people-
better
like
place
most
than we
people.
were before this last hit. So you made a blog post.
I made a blog post.
You made a blog post. Congratulations.
Oh, you made a blog post.
Hey, what's that?
What's that? Deborah Ronker's been a
Debbie?
member for 20 months.
Has been a member for 20 months. So we don't talk much
Congratulations.
about membership on the channel. We don't do that much with it, but it does get people special little.
And Bianca's been a member
And
for
Bianca's
33
for 33 months. Wow! Congratulations,
Excellent.
both to Debbie and
Wow.
Bianca for.
I think that deserves a new car, $1 million, and a trip around the world.
3 years?
We'll let you give that to them.
Yeah.
So, in follow-up of last week's show, before we jump into value-based care, thank you. We were talking about tests and preventive, and there's this concept of the whole body scan. Usually, when I hear whole body scan, I think CAT scan. But we actually got records today from a married couple who had his and hers full body MRI And
I wonder what it's like. Maybe an anniversary gift.
I guess.
Don't do it.
And no, they don't make couples MRIs. You have to do it individually. It's not like the bathtubs on a Cialis commercial. So, and you'd have to be really close if they stuff 2 people into one of those machines. That would be really, really tight. But no, they did them separately. And let's see, one of them was 35 pages long, the readout from the MRI, going over everything and every abnormal thing that they came across that now somebody has to follow up on it.
Because it's an MRI, and you see everything.
Oh, my goodness.
Even things that don't
So 35 pages.
aren't
And
abnormal.
I'm looking everywhere on the 35 pages for who ordered this thing. I have the name of the radiologist, who, by the way, says, come back next year for your
Annual preventive
proactive.
something like that. Yeah.
Oh, my goodness.
Exam or something like that.
Full body MRI annually.
Annual
So that
MRIs.
every little thing that comes up that we don't know for sure what it is, they have to be tested on.
That's right. Boy, that's gonna.
Or get a biopsy, or get worried that they have an aneurysm or MS.
How much is that going to cost?
Cancer on my.
Would that be value-based care? What a segue.
Yes, please.
What a segue.
Take it away.
So value-based care, if you are a follower of the blog, you've read this, but if you're not, go sign up, check it out. Value-based care has been in development. We've been putting it into action for probably almost a decade now. It's getting there. In 2014, I think, is when the IHI, the Institute for Healthcare Improvement. Yeah, that's what the IHI is.
Not informatics?
No, they probably have one of those.
Probably.
But they came up with this quadruple aim, where they.
That's 4. It's like the triple
very
aim,
good.
except somebody thought it'd be cool to add the
They
4th.
added on the 4th one, which is an important one. The 4th one added on was clinician wellness, which is important because burnout is a huge issue within the physician.
But it doesn't matter if the
community.
physician's well or not, if what you're trying to do is make the patients well and the patient isn't well. So it really needs to be like a second-tier thing. It matters.
I would
It
disagree.
matters.
I think I could come up with a reasonable argument against that. Because
Okay,
if
so
you're not
only
well, you're
doctors
not gonna-
matter. Sorry.
It's a quadruple aim. That's one part of the 4th, not the whole thing. Because the other 3 focus. Well, 2 of the 3 focus on the patient, and one of them focuses on.
Yeah, I'm just
Costs.
stuck on having both a chief wellness officer and a medical director of wellness, both. Both speaking
What
at
about
meetings.
your medical director of the patient experience?
There's only one. Yeah. Yeah.
Yes.
Yeah.
Oh, Lindsay just
Anyways.
piped in here. Now, can you imagine tuning in late and all you hear is bathtubs in a Cialis commercial?
Yeah, that's how we're going to do
That's
our
what she
next
came
show.
in on?
That's how we're going to do our next show.
What? Were you going to be in the bathtubs?
Yeah.
That was Lindsay, by the way.
Wonderful.
See, the worst, the awful thing is I would do it.
We just got to find. My parents used their clawfoot bathtub.
Oh.
That one's still.
Wait. Didn't that stay in the old house?
Yeah, that's what I'm saying. They used it, so I
oh.
don't have access to it. They sold that.
Yeah, let's get a different mental image here.
Anyway, back to the quadruple aim. So let's go back to the other parts of the quadruple aim. So we talked about physician wellness. The other 4 are.
He doesn't even look, but he knows.
The other 4 are lowering costs, which is important, and I'll get into why that's important. Better health outcomes, which fits with like clinical quality. We'll talk more about that. And then improved patient satisfaction. So that's the other side of that. So it does take into how the patients are receiving their care. So patient satisfaction is pretty clear, in my opinion. We want to make sure that you're having a good experience. We do surveys in our office about that.
Well, you could have good care and really just upset the patients, but they still got good care. But the reason it's important is because
As the medical director of patient experience,
but
I would disagree that would be good care.
But we know that good care is better when the patient has a good experience because they're going to actually have better results and follow through.
And they're going to follow through. They're going to.
So, there you go.
Yeah. Anyways, lower costs. Why is that important?
Well, you have to be able to pay for it or it doesn't happen.
Right. Yeah. And unfortunately, the U.S. is known for our healthcare costs.
We're like one of the top.
We are number one of all Western.
So how are outcomes?
Not as good as they should be for someone who has more spending.
Pretty low on the list of
of
what nations?
Western civilized of the Western
well-to-do nations. Anyway.
Developed. That's the word. Yeah. So we spend about 20% of our GDP on. On healthcare. 20% of our GDP. The next in line, I think, is the UK. You're number 2, UK, at 13%. Which is a pretty staggering number that much is going into. And that number, unfortunately, continues to rise for a variety of reasons. Our boomer population continuing to get older, the cost of medications going up. Well, lots of things go into that. But that is one of our primary goals, to try to lower costs. Yeah. And it makes sense. And it's an important goal because it's just out of control.
It's part of the quadruple aim.
It is. Yeah.
Just to be redundant for you.
Just to be redundant, yes. So our outcomes are not much better. Despite that, we do we're neck and neck in some of them, but some outcomes were not as good.
Infant mortality. Our longevity.
How long we live is just not as.
So who are we comparing ourselves against when we say we're not as good? Would that be like Sweden?
Right. Yeah. It's all those
socialized medicine,
European countries and Canada. Okay. Those places, those Western civilizations.
Interesting.
Yeah. So it kind of just begs the question: how can we improve that? And that's where value-based care comes in.
Okay.
So.
Not couples whole body MRIs annually.
Yeah, so that would
somebody's going to have to go over those results.
Fly in the face. That is like the epitome of anti-value-based care. How can we spend the most amount of money and continue to start this money generating paying machine?
If you don't know why, watch last week's show on.
We've got our soapbox on that one for sure. Yeah. So that is the cost, and then that other one we were talking about, clinical outcomes.
Yeah.
That talks about or goes into. Like making sure our patients are hitting certain metrics for different.
A basic one is not dying.
But, and if you do, don't go to the ER.
But actually, don't go to the emergency department before you die, please.
Well, if you're on hospice or end stage something, probably not the best to go to the ER. But anyways, that would be like hitting certain blood pressure levels in our patients with high blood pressure, or hitting certain A1C levels for diabetes. For those of you who don't know what that is, that just means getting their blood sugars under control.
Yes.
It means not doing certain things, like not prescribing antibiotics for a viral diagnosis.
Please stop doing that.
If you're a doctor, don't do that.
Yes, please.
There are, how many are there? Last time, like 22?
Well,
there are a lot.
If you went through all of them, probably something like that.
Yeah. We so
not doing C-sections.
C-section rate, obviously, we can't affect that one. There are some that are very specific to specialists. Statin use in those with heart disease.
Cardiologist,
if it hits the cardiologist.
I guess we should clarify. They want this cardiologist to be using the statin.
You should be on a statin.
And the patients who benefit from it. Yeah.
Yes.
Not the patients with low risk for cardiovascular disease who are over 75. That may not be the group that we want.
Right. Yes. The idea behind this is that we are actually, the U.S. healthcare system is changing the model of payment. So it's no longer see as many patients as you can and get paid for seeing each one of those patients. No, it's actually see patients and get them under control and then get reimbursed for how well you're doing your job at getting them under control.
Paying for what you get instead of just paying for busy work. And so it's a shift. Older doctors, they're in the habit of,
just run them through. See
20
15
plus
patients in a half day.
Yeah, getting 20 plus patients by the end of the day, and being able to bill for all those codes for each individual visit. And the shift is to getting paid per patient per month.
Right. Capitation.
Whether you have them come in the office or not.
Yeah.
And then getting the rest of the payment if the patients do well with their health.
We actually recently went to a capitation model with one of our, I guess it'd be insurance. And they actually showed us the numbers of which doctors are going to be making more, versus those who are not.
Yeah, it was a mix.
It was. It was literally
not everybody
like
was in favor
above,
of it.
half below, some right in the middle. We do well at keeping our patients out of the doctor's office unless when absolutely needed. So we were on the beneficial side of that.
So the doctors who are going to do well are the ones who keep their patients healthy and not needing the hospital, and the patients who the doctors who had a shift in how they got paid were the ones who
weren't happy.
They saw the patients a lot and they billed a lot, but
it's a change in mindset with caring for patients for sure.
Who would you rather have as your doctor?
The one that doesn't see me every month just to bill my insurance.
The one that keeps me out of the hospital.
How about the one that actually gets those numbers under control so I'm not ending up in the hospital?
Yes.
So,
thank you.
That's kind of a brief overview.
Yeah, that is a brief overview of it.
I quickly touched on a recent study as well.
Let's talk about that.
Oh, you want to talk about that?
After Mr. Ed says whatever he was going to read there.
Oh, no, I was just going to go back to, let's see. It was Debbie who said I had a full body scan after my thyroid cancer. And then down here, my husband had his left kidney removed as he had cancer in it, and they did not do a whole body scan.
Well, kidney cancer is pretty isolated typically, and if you take it, it typically has not moved.
Depends on the report after the surgery.
Right. Yeah, you can look at that. As far as scans,
so
there
would
are
probably be a
PET scan.
rather than
So there are
MRI.
appropriate scans to look for metastasis.
Well,
when
that
you have
wasn't
cancer.
screening.
No, and that's not screening. That's not, hey, I want an MRI, please.
That was this
Order
person
one
had
for
cancer.
me.
We need to check.
Yeah, there's a reason for it. So different circumstances for sure there.
Yeah.
Yeah.
Oh, okay. So let's go on to your
The article.
that
In Mississippi.
Let's talk about that.
Yeah, this was
talk about
kind of an interesting article where for this clinic, they had a lot of, they call them APPs. We call them APCs here in my article. I refer to them as APPs, Advanced Practice Providers, I think is what.
Yeah.
But it essentially refers to PAs and nurse practitioners. And they can provide care at the quote-unquote level of a doctor. And they essentially had them provide that care, and then after 15 years went back and reviewed their data and found that it actually cost the system more to have care provided through an APP.
Now, let's be very, very clear here. This was one without a doctor right there available for their questions and to help them make decisions. So what would they do if they didn't have the doctor to go to?
Order more stuff.
Order more
try
stuff.
to figure it out. It makes
more
sense.
referrals.
Yeah, it makes more sense. It makes sense once you think about it. If you nurse practitioners, PAs, a valuable part of the team, and we utilize them here, and ours are wonderful, and we love them. They often come to us with questions, though, and we appreciate it. We welcome that, and we ask them questions or answer their questions, and often tell them appropriate tests to order or not order based on what they're telling us, or not refer, or go down a certain pathway instead of just sending it to the specialist.
A lot of times we'll say, "Oh, we can do that procedure in-house. Schedule them with me."
Yeah, absolutely.
If it's a procedure they're not comfortable doing, you've got somebody in the office that can do it. One of the doctors.
Yeah. So the whole idea is, I think the reason for this article was they were arguing against APPs practicing independently. And it's a good argument. APPs just don't have the clinical expertise
in an office by themselves.
To be on their own making all the decisions. And I'm not denigrating those APPs, APCs. I'm just saying that's what the data shows. But they are still a valuable part of the team, and a valuable way, or a good way for physicians to expand the number of patients they can see. In our office, we have 2 doctors, and we only have so much time, and we can only see so many patients. And we get requests all the time for people to get into our office. We do. So the way we
turn away
we do
dozens of people a week.
Yeah, and our panels are full. We see our patients and we're full. So our new patients are able to get their foot in the door and see and be able to be seen at our practice through those APPs. And it is a good way for us to be able to expand our footprint here in the small city where we live.
And be available to more
provide
patients.
more care, yeah. It's an interesting study. Definitely argues against independent practice for those APPs, but
that's confusing.
We want to. I know
language there, because this is an independent practice and we have them, but they're not independent from us.
Right, yeah. So a lot of states every year will come up with some sort of legislation trying to allow these advanced practice clinicians to practice on their own without the oversight of a doctor.
Yeah.
And you talk to some of our doctor friends, and they are very vocal about that.
But I don't think it's based necessarily on the data that you were talking about.
No.
I think it's just protection.
Yeah, they don't want their job to be farmed out, I guess you could say.
Looks like Mr. Ed has something.
Yeah, we have a new listener or observer from South Wales.
Oh, my
United
goodness.
Kingdom. I do enjoy your lives. That is a Lou James. Is it Louise or Lewis?
We don't know.
Watching live.
Was there an E at the end?
Lou, L-O-U.
Oh, Lou. Oh, okay.
South Wales.
Welcome, Lou. Thank you for letting us know. Not New South Wales, but actual South Wales.
Isn't New South Wales in Australia?
What time would it be there?
Okay.
And then South Wales would be south of.
She's up late. It's like
that
midnight
would be
there, isn't it?
How many hours ahead of us?
9
That
or
would
10
probably be.
o'clock?
Yeah, it's late.
It would be late.
These people are having trouble sleeping.
Listen to the sound.
So
of
they
our
look
voice.
at this.
This is going to put you to sleep.
Thank you. We're
I
glad.
bet Mr. Ed's voice could put me to sleep.
I bet you people in New South, not New South.
Not saying you're bored. That's not what I'm saying.
I bet you people in South Wales love our
will
accents.
tell.
Love our wonderful accents. New South Wales. What kind
Not
of
new.
No, you're right.
South
South
Wales.
Wales.
South Wales.
I don't even know that accent.
Oh, it's out there. Yeah.
There's so many accents within the English.
To us, yeah.
Yeah.
Okay. Anything else before we wrap up this great program?
I don't think
Maybe
so.
we should talk about what next week's topic is. So next week, we will be talking about medical advice.
Well, that's general.
Yeah, I know. So you can read the description. I don't know if they can read the description.
One of these times soon, we have to talk about a more basic thing. There are people getting ready to go on summer hikes and mountain climbing and simple little.
Oh, is it that
They
time
break
again?
a leg or they sprain an ankle. They don't know whether it's a sprain or a break unless the bone is protruding. And there's other things. Snake bite. What do people do on the site for a snake bite?
Pee on it. No, just kidding. That's something.
Suck the venom out.
Suck the venom out. But don't do that. Pee on it after you do that. Wait, is that right?
Pee on a snake bite.
No, that's athlete's foot.
Athlete's foot. Oh,
There-
jeez.
Okay, there is some protective.
Yeah. So we are getting out there where people are. I
Is that what we need?
usually have a
Is that what we need to do?
summer post.
Okay,
It's
that's-
usually in May that I do
We'll
that.
we'll
but-
talk. Well,
But we could do
I
it.
was going to say next week will
May
be
is here.
We'll be next
It
week.
is May.
All right,
Oh, my
so
goodness.
we'll talk about summer
Where
activities
did
next
April
week.
go?
Both Dr. Quayne and myself. We'll talk about summer activities. So,
All right,
anybody
summer
you need
activities.
to thank for?
Absolutely.
Being a part?
Go check it out. The blog over at Dr. Green Knight. It's just that.com. And over there, I do have a Patreon. Appreciate the support, especially to Teresa. Thank you for what you do.
Yeah, absolutely. And also thank you to Lindsay and Twine. Until next time, we have Holly, Mr. Ed, Dr. Quayne, and myself.
The
telling-
live audience. Oh,
Telling all of you to stay in good health.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.